Hello, my name is Sangeeta Shah from VCU Health in Richmond, Virginia. I hope this educational video is helpful for not only studying for the boards, but also for performing clinical imaging when taking care of these adult congenital heart disease patients. Another speaker will be covering ASD, VSD, PDA, and AV canal defects. So you may say, what am I covering? What's common? Isn't it those simple congenital heart disease? I will challenge you and say common means occurring often. As the number of adult congenital patients increases by at least 5% per year, you are likely to be a provider of care in these patients. So I hope you use some of these pearls to do so. What we will be covering is we will recognize the congenital anomaly and its associated findings. We will talk about the surgical interventions and then discuss what are the postoperative complications that we are to look for in cardiovascular imaging. The anomalies we will be covering are Tetralogy of Fallot, transposition of the great arteries, Ebstein's anomaly, and LV outflow tract stenosis. We will have several cases throughout this talk. So let's start with this one. This is a 49-year-old with Tetralogy of Fallot, repaired in 1971, who now complains with symptoms of malaise, fatigue, and palpitations. EKG here shows a typical pattern, I should say, of normal sinus rhythm with a right bundle branch block, and the QRS duration is 180 milliseconds. On echocardiography on both of these parasternal images, you notice that the LV is normal in size to small. The RV is severely dilated, and you get this abnormal septal motion on both images, which is D-shaped in diastole, suggesting RV volume overload. What you see here by color flow Doppler and continuous wave Doppler is that to and fro severe unrestricted pulmonary regurgitation that is seen postoperatively in these tetralogies. You see the color flow here. And then by continuous wave, you see that the reversal of flow and the forward flow have the same density. And the pressure half time on this regurgitant Doppler is less than 100 milliseconds, suggesting severe pulmonary regurgitation. Continuous wave Doppler is very important across the pulmonary valve when looking at a post-op tetralogy. Sometimes color flow Doppler can be deceiving. I have placed this strain imaging of the RV free wall, which helps us to see what the RV contractility is in these individuals. The septum often has abnormal septal motion, so it is difficult to assess in these patients. What you notice here is the RV free wall strain, -15, -15, and -20 would average to about a -18, 17, 18, which is normal in this patient and population. Cardiac MRI is often performed in patients with Tetralogy of Fallot. This image is a cardiac MRI showing the RV outflow tract, remnants of the pulmonary valve. And what you see is this regurgitant flow, this dephasing flow that you see, which is pulmonary regurgitation. You as well see is that there's normal contractility of the RV here, and then basically akinesis or no movement of the RV outflow tract here. This means that there is a transannular patchwork put in this patient during the time of surgery to augment the RV outflow tract. Here we are able to measure flow through the pulmonary artery, and just like continuous wave by echocardiography. By MRI, you have this regurgitation volume, which is almost equal to the forward flow through that pulmonary valve. So the cardiac MRI, in conclusion, would show that the LV size and function is normal. RV is massively dilated at 248 cc's per meter squared. RVEF is reduced. However, you have to understand that in this cardiac MRI tracing, we are including that transannular patch, which is akinetic. The right atrial volume is increased at 21 centimeters squared. And as we've talked about the unrestricted PI, large RV transannular patchwork, dilated PAs, and in this patient, the aorta was normal in size and has a left-sided aortic arch. So let's talk about Tetralogy of Fallot and what it's associated with. So the anomaly itself is RV outflow tract obstruction. So it can be in the infundibular, the pulmonary valve, or the PAs. You have an overriding aorta where the ventricular septum actually points to the middle of that aortic valve. You have a resulting VSD, and the obstruction leads to RVH. Associated findings are atrial septal defect in a third of patients, so it's common. A right-sided aortic arch. Patients often have the genetic abnormality of DeGeorge's or 22q11, which is a partial miss in chromosome in the chromosome 22. And these patients generally have abnormal faces with a flat nasal ridge, wide set eyes, low ears. Their chin is underdeveloped, and they often have heart defects. This is also associated with an LSVC, which generally drains into the coronary sinus, and coronary anomalies in 10% of patients. Palliation. So what's done in these individuals? First, initially, they would develop the pulmonary arteries, and they would do this by having a connection arterial to PA. You could also have something called a Waterston or POTS procedure, where the Waterston would be ascending aorta to the right PA, and then the POTS would be the descending aorta to the left PA. The important reason to know whether someone had one of these shunts, depending on how long they had these shunts, these patients can develop pulmonary hypertension. After palliation, many of these patients, most of these patients, had repairs with closure of the VSD, the transannular RV outflow tract patch, as we noted in the previous patient, augmentation of the pulmonary arteries. If the RV outflow tract was not augmented, sometimes there was severe stenosis or there was a coronary anomaly, the patients could end up receiving an RV to PA conduit. Briefly, I'm just going to show you the timeline of surgery, and this helps us understand, if we're seeing a patient in clinic, what procedures they may have had done. Most importantly, the BT shunt occurred in the mid-1940s. The first tetralogy repair occurred in the late 1950s. And then we have gone away from performing shunts and trying to see if we can have the individual undergo a primary repair. And that started in the 1980s. By the early 2000s, we are now able to perform percutaneous transvalvular replacement. What are the post-op findings that we are looking for when imaging these Tetralogy of Fallot? So just like I showed you in the first case, we're looking for pulmonary regurgitation. We're looking for pulmonary artery or branch PA stenosis. Sometimes when patients have had shunts placed, they can develop scar tissue there. We can see the akinetic RV outflow tract with RV dilatation and dysfunction due to the severe unrestricted pulmonary regurgitation. Very commonly, we will see aortic root dilatation in these patients, including the ascending aorta. We can have residual shunts, mostly through the RV, but it's important to look for these residual shunts, as it also helps us decide on if these patients need endocarditis prophylaxis. We're trying to measure for LV dysfunction. So this is important to characterize. As the RV begins to decompensate and become dysfunctional, the LV also becomes dysfunctional. These patients often have arrhythmias, atrial as well as ventricular. Treatment for these patients with severe unrestricted pulmonary regurgitation is pulmonary valve replacement. These patients, when they do get pulmonary valve replacement, have regression of their RV volumes, have improvement in our functional class. They have improvement in LV function as well. This all has to be balanced with the risk of the procedure. And what I'll tell you now is many of these patients are able to undergo percutaneous valve placements. When looking at the guidelines, I just want to, this is the 2018 ACC/AHA Adult Congenital Guidelines. Imaging plays an important role. So if somebody has moderate or more pulmonary regurgitation, and you are trying to decide whether they need to undergo pulmonary valve replacement, they need to have two of the following if they're asymptomatic: RV or LV dysfunction. By MRI, RV end diastolic volumes greater than 160 or RV end systolic volumes greater than 80. Increased RV systolic pressures greater than 2/3 systolic, and progressive exercise intolerance. So CPET is often used in these patients for serial follow-up. So let's go through another case to kind of go through what we've learned. 38-year-old with repaired Tetralogy of Fallot in 1979 had an RV to P8 conduit. Since then, he's had a history of every arrhythmia, atrial flutter, which he's had undergone ablation, VT, and complete heart block. And he now comes with a pacemaker and an ICD. He has noticed worsening exercise intolerance. So on these two parasternal images, you notice that the ventricular septum is very different than it was in the previous case. You see that the LV, probably low normal to mildly depressed. RV does not appear severely enlarged, but does appear depressed in function. The mitral and the aortic valve in these limited images look normal, but most importantly, look at the ventricular septum. It does not have the D shape that we would see in systole or diastole, and we'll see why. So here you see the conduit, the pulmonary valve conduit, and then you see color flow Doppler. The velocity here is 80. So you can see that there is significant pulmonary regurgitation with the red. And then you see flow acceleration, the PISA going forward, the blue showing stenosis. Here by continuous wave Doppler, what you see is above the baseline. The first pulmonary regurgitation jet has a short decel time. The latter two are a little bit longer. The intensity of the backwards flow is almost, but not completely equal to the forward flow. So this looks like at least moderate to severe pulmonary regurgitation. You look below the baseline and you see the continuous wave Doppler is 4 meters per second, peak velocity of 65 millimeters of mercury with a mean of 38. The reason that the ventricular septum is midline is because this patient has both PI and PS, giving that septum that look. So because this patient is having symptoms and the RV is enlarged, there is reduced RV systolic function, there's moderate to severe PI and conduit stenosis with an RV pressure of greater than 70 millimeters of mercury, it was recommended that he undergo percutaneous valve-in-valve placement. Moving on to our next anomaly, and we're going to spend a little bit more time on this, is transposition. So let's start with our case. This is a 32-year-old born in 1980, transposition. It was a detransposition. diagnosed with a viral syndrome who just hasn't gotten better and presents with dyspnea on exertion and fatigue. EKG shows atrial reentry tachycardia with a heart rate of about 150 milliseconds. There is RVH on this EKG as well. So let's look at these two images. We have an apical four-chamber and a parasternal short axis. In the apical image, this is the tricuspid valve. Generally, it is more apically displaced, and therefore this is the tricuspid valve. The valve always travels with the ventricle, so this is your right ventricle. This is your left ventricle, and here's your mitral valve. So in detransposition, the left ventricle is connected to the pulmonary artery, and the right ventricle is connected to the aorta. In this image, the right ventricle is on top and the left ventricle is on bottom. Once again, the right ventricle is connected to the aorta, the LV is connected to the PA. And here you have a D-shaped septum during systole, suggesting RV pressure overload. This is because the RV pressure is higher, it's systemic, compared to the LV pressure, which is pulmonic. So this to me means that the pulmonic pressures are normal. TE was performed on this patient because of the atrial arrhythmias. And what you see here is classic for transposition of the great arteries. You have parallel great vessels. Here is the aorta, which is more anteriorly and connected to the RV. And here is the pulmonary valve and PA, which is connected. What you see here is remnants of a baffle, which is used to reroute the blood in the atria. Here you see a VSD going from right ventricle to left ventricle. The right ventricle pressures are higher than the left ventricle. Please note that the VSD is continuous flow during systole and diastole. It's just that it has a greater amount of flow during systole. Here are the baffles, which are rerouting flow. This is your tricuspid valve. So this is the flow coming in through the pulmonary veins to the right atrium, to the tricuspid valve, and the systemic RV. We put color flow Doppler, and we see that there's flow across the baffle. Remember, these patients have surgeries as children, and we often get baffle leaks in these individuals because of the stretch of the heart. And so you see about a small baffle leak here, and then you see about 2 more right here. Again, we do cardiac MRI in congenital heart disease often. And you see here is images through the baffles as they get routed. So what you see is here's your pulmonary vein coming in. Here is your IVC being baffled over to your left atrium. Here's your SVC being baffled towards your left atrium. In this image, you see the tricuspid valve and the right ventricle out to the aortic valve. So don't fret. I know this is confusing. What's connected to what? The right is and the left are switched and what's connected, but let's go through this systematically. When you think of congenital heart disease, and especially transposition, I want you to write down what are the segments and what are the connections. And if you can write this out, you will understand it every single time. So on segments, we have the great veins, which is the SVC, IVC, pulmonary veins. We have the atria, we have the ventricles, and then we have the great arteries, the pulmonary and the aorta. How are these connected is what you want to understand. How does the SVC, IVC connect to the atria? How do the pulmonary veins connect to the atria? How does the atria connect to the ventricles? That's aortoventricular connection. How do the ventricles connect to the great arteries? What is the ventriculo-arterial connection? So these are two images, and on the left you have detransposition of the great arteries, and on the right you have left transposition of the great arteries. I'm so sorry I put them in that order, but I'm gonna stick with it. What you always wanna remember in transposition is that the aorta is anterior. The aorta travels with the RV, and the valves travel with the ventricle. What you notice with detransposition is the RA is connected to the RV, that is concordance. But the RV is connected to the aorta, that's discordance. The LA is connected to the LV, that's concordance, atrioventricular concordance. And the ventricle is connected to the PA, which is discordance, okay? With L transposition, you have two discordances, and therefore you can live and not need surgery. So now you have atrioventricular discordance because the right atrium is connected to the LV. You have ventricular arterial discordance because the LV is connected to the PA. So with detransposition, you've got to look for concordance and discordance, okay? What is it associated with? ASD PFO, very common. It's actually needed for survival when you are born. Often patients undergo a septostomy in the first few hours of life. There's generally a VSD that's associated with this in 40%. There can be RV outflow tract obstruction, LV outflow tract obstruction, aortic arch obstruction, and anomalous coronary arteries. For the reasons for exam, I think the most common associated abnormality that you need to know is the ASD and the VSD. Again, I'm going to show you the surgical timelines of how we learned what we were doing so that when you're seeing a patient, you can have some idea, or when you're imaging the patient, you can predict what they've had. We did perform surgical atrial septostomy in 1948 was the first time. Atrial switch procedures started to occur in the 1960s. These are called Mustard and Sennings. Balloon atrial septostomy occurred in 1966. So now the patients did not have to go open heart surgery initially when they were born. And then arterial switching of the great vessels started to occur in 1980. This is an image of an atrial switch. This is what it looks like. One on the left, I have color coded it. It's rerouting blood of the SVC, IVC into the left atrium, and the pulmonary vein flow comes behind that. On the right is another drawing depicting the same. What are complications that we are looking for? We can see systemic RV failure. It is not meant to have those systemic pressures over a lifetime. As the RV begins to fail or get dysfunctional, you get systemic tricuspid regurgitation. You can get baffle leaks, as I showed you in the first case. You can get obstruction as well. That SVC baffle is known for developing obstruction. And it's important to notice by imaging before putting a device in, such as a pacemaker. These patients can develop pulmonary hypertension and arrhythmias. So this is an example of someone who had SVC baffle stenosis and then underwent stenting. You can also see that when you have a baffle leak, we can have percutaneous closures of this leak. So let's talk about this gentleman. He's a 38-year-old with transposition of the great arteries who presents with syncope and heart failure. He is detransposition. Here is the echo images. Once again, I'm going to call your attention to the septum. Remember with detransposition, I explained that the septum should be bulging towards the left ventricle in systole, and that would be normal because your RV pressures are systemic and your LV pressures are supposed to be normal. In this one, the ventricular septum is midline. You also notice that there is a pacemaker or device in the left atrium. This is the LV, which is the subpulmonary ventricle. It is severely reduced. The RV up here is enlarged, is well severely reduced. On this image, you see the RV does not move and the LV has severe dysfunction as well. So this individual had sinus node dysfunction, re-entry atrial tachycardia, that because they have all that scar tissue from the baffles and the atria. They have biventricular failure and had severe pulmonary hypertension with the PA pressures of 100. Unfortunately, he died within 5 years of coming to clinic. He died at the age of 41. So in the 1980s, we were able to progress to the arterial switch procedure. And this has been revolutionary in the care of these patients. Basically, we are reattaching the pulmonary vasculature to the RV, and we're reattaching the aorta to the left ventricle. So what does this involve? It involves one, reimplantation of the coronary. So you see the buttons being taken off the aorta and being placed on the pulmonary artery. You have transection of the pulmonary arteries above the semilunar valves. So you can see we've cut them, and then we reattach it. When we reattach it, we are pulling that PA more anteriorly, which is called the LeCompte maneuver. I will show you pictures of this. One wording I want you to get used to is that when we switch it, that proximal portion of the PA and aorta, that aortic valve is now becoming a neopulmonary valve. And the pulmonary valve is going to function as an aortic valve. So if you can imagine, these valves are now still going to do the process of the other ventricle. So it may lead to complications in the long run. This is a beautiful image by cardiac MRI of a LeCompte maneuver, and you can see how the PAs are straddling around the aorta during this procedure. I will also call your attention as this image comes back around to the proximal aortic or neo-aortic root, and you can see how it's dilated. And that occurs because that was previously the PA tissue. Here on axial images, you see that how the PA is wrapped around the aorta, and this can lead to pulmonary artery stenosis, branch PA stenosis. So detransposition with arterial switch. You can get supravalvular PS, branch PA stenosis, sorry for the typo, supravalvular aortic stenosis. You can get valvular regurgitation. More often, the neo-aortic valve will regurgitate more than the neopulmonary. And you can get dilatation of the neo-aortic root, as I showed you previously. So let's look at this 25-year-old rower who had detransposition with arterial switch. When you look at the LV, it looks completely normal, good function, and you couldn't tell that he's had surgery other than the scar when you're imaging. Again, the 4-chamber on cardiac MRI looks normal. Here on axial images, you see the LeCompte maneuver with the division of the right and left PA. By cardiac MRI, we look at the pulmonary arteries and we measure flow in both the right and left pulmonary arteries to see if there's any differential of flow. Here you see the aortic valve or the neo-aortic valve, and you have dilatation of the sinus of Valsalva here. This is again appreciated on these axial images on cardiac MRI. So moving on to L transposition, which is also known as congenitally corrected. Remember, this anomaly is associated with a double discordance, which allows you to live. It's associated with Ebstein's anomaly and subvalvular pulmonary stenosis. So let's discuss a case. A 53-year-old male with LTGA has a history of complete heart block who presents with a pacemaker and now has symptoms with heart failure and atrial fibrillation. I wanted to show the TEE image. On this image, I'll call your attention to look at the apical displacement of the tricuspid valve. Therefore, this is most likely the right ventricle. This is the left ventricle. This is the left atrium. This is the right atrium. You see a lead in the right atrium on this image. Here, just like I showed you before, the parallel great vessels, here you see both great vessels in short axis. Remember, the aorta is always more anterior, and here is the pulmonary valve. So what are the complications? They get RV systemic failure. On that previous echo image, the RV was dysfunctional. It's a systemic RV. You get tricuspid regurgitation, and heart block is very common. So let's move on to our next anomaly. This is an 18-year-old who presents with abnormal EKG. What you notice here is sinus brady, but you have a delta wave consistent with WPW. I think on this parasternal image, what you first notice is that the tricuspid valve is in plane. And so you have to investigate further why is that? LV function is reasonable. The septum has a funky abnormal motion that doesn't fit any strict criteria on this image. Here are two short axis images, which helps us to show an enlarged right atrium, the abnormal tricuspid valve, which is associated with significant severe tricuspid regurgitation, and a small, normally functioning LV. Here is an apical image. And you see that the tricuspid valve is apically displaced. You see that the motion of the anterior leaflet is pretty good on this one, which is important when assessing Ebstein's anomaly. You also see this abnormal septal motion, so you really need to investigate for any shunts at this level. Here's the severe tricuspid regurgitation, and if you look carefully, there's a hint of flow that occurs in this left atrium, suggestive of possibly an atrial communication. So this is Ebstein's anomaly. And what I'll tell you is, for definition, many people will use this strict definition of greater than 10 millimeters displaced from the mitral valve, or greater than 8 millimeters per body surface area. What I really want you to pay attention to is the spectrum of Ebstein's anomaly, because that helps us tell the patient the prognosis. If you look at the top, there's a normal tricuspid valve, and you look at the attachments of that anterior leaflet. As the Ebstein's anomaly is on the spectrum, the bottom image shows you the spectrum where the anterior leaflet is connected, more connected, very much more connected by the third image. And then you have atrialization of the RV because there is no motion or mobility of that anterior leaflet. And that's why we call the septal leaflet like a sail, because it is trying to reach and get to that anterior leaflet. So please pay attention to the amount of motion of that anterior leaflet as you are looking for patients with Ebstein's anomaly. Ebstein's anomaly is associated with ASD-PFO, as I've already mentioned, WPW. It is also associated with left-sided lesions. The most common that I have seen is non-compaction, followed by bicuspid valve, and then mitral valve prolapse. When you're looking at severity of Ebstein's, there are two ways to grade them, and these are the two. You got the Carpentier and the Salamander major, sorry. And I'm not gonna read through this exactly, but you can see how this works. Basically, in the Carpentier, you want to see how much of the valve is restricted and how much of the RV is actually exist. And so by the time you get to type D, you basically have not significant amount of RV, and actually you don't have very significant amount of RV outflow tract. The concept is same here. They're measuring on a 4-chamber the ratio of the area of the right atrium and the atrialized RV compared to the area of the remaining of the heart to help determine the severity. So this is a 48-year-old who presented for cardiac MRI actually last Thursday. And he had new onset heart failure. And the reason that he was sent for the MRI is because they wanted further evaluation of the non-compaction, which is very reasonable. And what I'll show you is that these are his images. He does have non-compaction of a significant portion of his left ventricle, but you see this tricuspid valve, which is apically displaced and looks like Ebstein's. When you look at the RV outflow tract, he has good amount of RV outflow tract. You see that the anterior leaflet has good motion. The black flow here is dephasing, suggesting tricuspid regurgitation. On the severity, this comes into the severity of type B or class 2 because there is not significant atrialization of the RV in these images. Going on to our next anomaly. Let's start with a case, of course. And this is a 53-year-old female with hypertension and murmur who presents with dyspnea. Here are her parasternal images. What you'll notice is that there's flow acceleration in the LV outflow tract with color flow Doppler. There's a little whiff of AI, normal ventricular function. And once you see where the flow acceleration is, if you bring your eyes back here, you will see a little nubbin or a little ridge. So we go to our apical 5-chamber images. And when we do that, we once again, when we put color flow Doppler, you see the flow acceleration occurring right at this level. And if you were to take the color flow Doppler out, you would see this ridge. This ridge is connecting to the anterior leaflet of the mitral valve and the ventricular septum. This is a subaortic membrane. Continuous wave Doppler shows a peak gradient of 60 millimeters of mercury and a mean of 34. You see above the baseline, there is also aortic insufficiency. So when you're looking at subaortic stenosis, there's generally 2 types. The most common, actually 3 types. The most common that we encounter in adults is the membrane, which is an 80%. And that's generally 1 to 2 centimeters below the aortic valve. But you can also have a muscular tunnel. I'm sorry, 1 to 2 millimeters below the aortic valve, not centimeters, 1 to 2 millimeters. You can also have a muscular tunnel, which is about 10 to 30 millimeters throughout the LV outflow tract. We also have to pay attention to after many congenital heart surgeries, you can develop LV outflow tract obstruction. Associated anomalies with subaortic stenosis, aortic valve abnormalities, so they can have bicuspid aortic valve. You can have a VSD, Schoen's complex, coarctation. In Schoen's complex, you're looking for levels of stenosis in the left ventricle, so you can get a supravalvular stenosis, you can supravalvular mitral stenosis, you can get a parachute mitral valve, you can get the subaortic membrane, a bicuspid, and a coarctation. You can also get AV canal defects associated with subaortic stenosis, and it is seen in double chambered right ventricles. Sorry, double outlet right ventricles. Repair is when you have a peak of 50 millimeters of mercury or a mean of 30. That is a typo, a mean of 30, you would correct. And you can have surgical repair. And initially in the adult population, often there is a membrane resection that occurs. And what we have to understand is that patients, about a third of the patients can get reoccurrence of their membrane. So don't be surprised if your patient has a resection and then gets, you need to continue to follow them with imaging and for symptoms because there can be a recurrence. There is a procedure, and I just want you to understand the word cono because that may come up in a question, and you just have to understand that it's associated with LV outflow tract obstruction. And basically, I've put a picture here, but basically you're having a cut through the aorta, through the RV infundibulum. You expose the anterior septum, also known as the conal septum, and you have enlargement of this conal septum with resection of that subaortic membrane. And this prevents recurrence, and used in patients also with tunnel subaortic stenosis. As you see, there's a lot of reasons that patients get scar tissue from this because they then have to close and suture your RV infundibulum as well as your aorta. So I'd like to put these three pictures up because they're great for test question comparison. So on the top left, what you see is someone with classic subaortic stenosis or aortic stenosis. You wouldn't be able to tell, but you have this classic mid-systolic acceleration, and you have this aortic regurgitation. In coarctation, you will have an increased systolic velocity, but please pay attention to the diastolic runoff. And that's how you know it's a coarctation obstruction. For dynamic LV outflow tract obstruction, you're going to have this dagger flow that you see here. In this case, you also have the mitral regurgitation that occurs with the obstruction in this image. So this is dynamic LV outflow tract obstruction that is typically seen in hypertrophic cardiomyopathy. I would like to highlight some articles that I've plugged into the talk, but if you want to do a deeper dive, these are great articles for multimodality imaging and transposition, multimodality imaging, and Tetralogy of Fallot. And then the guideline papers that I would recommend is the one by the ACC-AHA in 2018, and then the European Society published one in 2020. So remember, when imaging adult congenital heart disease, remember it's common, you're going to see it often. Understand the congenital heart anomaly, understand the associated anomalies with it, understand the surgeries that could have occurred, and then that will help you define the potential complications you need to look for by cardiovascular imaging. I appreciate your time. Thank you.